Thank you very much. I would like to thank the organizing committee for inviting me to give a talk on this important topic. Today, my topic is actually mending a broken heart in brief. The secret behind it to attract more people to my talk. We'll see. But actually, what I'm going to talk is I would like to talk on heart failure. So I will cover all the spectrum of heart failure. So within 1 hour, I'll try to fix most of your hearts. Right. So if you look at my overview, so I'll be talking on the background of the epidemic of heart failure, and also we talk about the new facts and evidence of heart failure in 2023, and also we are practicing on the guideline, that is HAOAC guideline, and we'll then go through clinical. Sorry. So if you look at the background, the heart failure actually has become an endemic. In globally, nearly 65 million of people living in heart failure, but this number is much more than this. Due to under-recording of heart failure in especially developing countries, and also if you look at the heart failure with preserved ejection fraction, it's not very recorded as it is. So it's under-recorded. And if you look at the mortality of heart failure, is having worse prognosis, even worse than that of cancer. So heart failure, the mortality is nearly 50% in 5 years. So that means out of only 50% of patients who was diagnosed with heart failure live 5 years. And also, it is predicted that by 2030, we are adding another 50% to these figures. And also, heart failure is not a very major cause for hospital admission, but it's major cause. Actually, it burns out the majority of health budget. Like that, once you get admitted, that they stay longer period of time, and also you need a lot of interventions and a lot of invasive and expensive procedures to cure them. So if you look at the natural history of heart failure, you know that it's a progressive disease. The end with death. So if you catch somewhere early, you can manage it. So there's a phase of compensation once all the risk factors is settled. So heart try, the physiological mechanism of the body try to compensate heart failure. Many of the patients are unaware of this stage, and also because they are asymptomatic, so this go unnoticed, and then come to the phase of chronic decompensation, that is slow and progressive. It takes some years, but gradually deteriorating their cardiac functions, leading to reduction in the pump activity and the other functional activities of the heart. And also there's parallel increase in the mortality and morbidity. But if you catch in this phase, we may be able to retard the progression, so then we can offer them extra life or extra years. We can add extra years to their life expectancy. And then this phase followed by acute or rapid decompensation. There is a rapid progression of the heart failure leading to the death. And in between, they may be having acute worsening and end up with hospital. So each and every hospital admission associated with 6 to 10-fold increase in death. So our aim is as a physician, and your aim as a doctors and medical student, to catch heart failure at early stage before they go into this acute deteriorations, so that we can do something to prevent acute deteriorations. So when you look at heart failure, everybody think that is ejection fraction. When the ejection fraction low, we think that their outcome is poor. Is there any relationship with ejection fractions and the outcome? There's no. Irrespective of your ejection fraction, their mortality, the poor survival is not associated with the ejection fraction. Is regardless of ejection fraction, the outcome is same. So that's a sad story. So if you look at the people over 65 to 69, in this is American data, so their life expectancy, they can live another 20 years. But if they have heart failure, irrespective of ejection fraction may be 40%, maybe 42, 50%, maybe above 50%. But their life expectancy is dramatically reduced to another 4 to 5 years. So it's across all the ages. And these ejection fractions, there is not a prognostic marker. But heart failure, if you have heart failure, your prognosis is poor. That means you are not, the chance of living more than 5 years, only 50%. So then we know that ejection. So we have some idea about strong mentality that heart failure and ejection fraction. But as I mentioned, ejection fraction nothing to do with heart failure. You need a definition. When you get a definition, we should have a universal definition where we can not so include as much as patients who are coming to this category. So if you look at the definitions of heart failure, what is the definition of heart failure? It's a syndrome with sign and symptom of heart failure. We know that this orthopnea, paroxysmal nocturnal dyspnea, fatigability, and shortness of breath with structural or functional abnormalities of the heart. So that is where cardiologist or echocardiographer is important, where we have to detect, we have to make sure that there is a structural or functional abnormalities of the heart, and is with one of following: either elevated BNP, but BNP can be elevated in other non-cardiac diseases without heart failure, like especially lung diseases and infection. There are so many other conditions where the BNP can be raised, and also BNP can be normal in heart failure, especially heart failure with preserved ejection fraction, especially in obese people, especially female. BNP can be normal. So BNP has a place, but it's not a gold standard. And also, then you need objective evidence of cardiogenic, pulmonary, or systemic congestions. So if you included everything together, the signs and symptoms, functional or structural abnormalities of heart with the rest BNP or the sort of congestion. So this is a very comprehensive definition where you can catch as much as number of patients to this category, so that you can diagnose heart failure with good sensitivity and specificity. So you need cardiologists to diagnose heart failure, physicians, even medical students make a diagnosis of heart failure with a higher sensitivity and specificity if you follow these definitions. Now, so there's no place for ejection fraction. But what is the place of ejection fraction in heart failure? Yes, still there is a place. When it classify the heart failure into different subgroup, ejection fraction maker is a determinant. So depending on the ejection fraction, we can categorize heart failure into four main categories. The heart failure with reduced ejection fraction, where the ejection fraction is less than 40%. With the pump is failing. And then you get heart failure with mid-range, where the ejection fraction is 41% to 49%. And the heart failure with preserved ejection fraction more than 50%. And then you get heart failure, the improved ejection fraction, where ejection fraction was less than 40%, now has improved back to all the 40%, so increased by 10%. These classifications and these demarcations are very, very important due to the several reasons. Your management is depending on these categories, and as why the pathophysiology of each of different subtype is different, and so that the management strategies is different. Like if you look at heart failure with reduced ejection fraction, the pathophysiology which make the heart more weak is the activations of a new hormonal system, that is angiotensin, renin, aldosterone system plus sympathetic activation. So that if you can block this pathophysiological pathways, you can get a better outcome. But if you come to the heart failure with mid-range ejection fraction, there is still activations of this pneumohumoral pathway, but it's not as great as heart failure with reduced ejection fraction. So that though you treat with the drug which are using for heart failure with reduced ejection fraction is not as effective as in this group. And if we come to the heart failure with preserved ejection fraction, pathophysiology is totally different. Actually, still we don't know why. The exact pathophysiology is not quite understood. So that the drug we use for heart failure with reduced ejection fraction not going to do any favor in these patients. So that if you treat them with this drug, so you are getting only the side effects. So that is very important. And then, so another classifications of heart failure, stage A, B, C, D, but I'm not going to read on this because it's just everybody knows it. Like initial stage, you get only these factors, and then get the structural abnormalities and the functional abnormalities. The patient is asymptomatic, and then they go into the clinical heart failure, and then the last stage is going to be heart failure, the end stage heart failure. Now, because my talk today is to Mending heart, so we'll mainly concentrate on the management of heart failure. Now, the heart failure management is different for different categories. And if you implement guideline and evidence-based treatment, so you can save heart and you can prolong their life expectancy. Now, but most of the time we are successful in heart failure with reduced ejection fraction, where the ejection fraction is less than 40. The reason is, as I mentioned before, renin angiotensin system or activations of sympathetic system. If you block this system, you will get the positive outcome. And also, we know that the cause of death in these patients, the cause of death usually homogeneous, like they end up with pump failure or the arrhythmia. So we can have preventive measures to prolong their life. And also we know that most of the time we know their etiology also. Etiology is also not very wide, and it's very homogeneous, like maybe ischemia, hypertension, and so and so. So we'll talk to the guideline recommended treatment. The first thing you have to make sure you have to treat the underlying etiology. So that is the most important. Maybe hypertension, diabetes, maybe coronary, so and so. So first you have to, if possible, you treat underlying etiology. Once you treated underlying etiology, so then you have to follow the guideline. So as I mentioned, this is actually a HA guideline. So there are 4 drugs we call quadrotherapy, which proven to be reduce cardiac endpoint, so death and need for hospital admissions and prognosis of heart failure. What are these drugs? The one, the blockage of renin angiotensin system. So there are 3 molecules which we can choose to block this system. Until 2014, we had only 2 molecules, that is AC inhibitors and ARBs. Now we have invented newer molecule called ARNI. What is ARNI? This is valsartan plus neprilysin inhibitor, that is sacubitril and valsartan. Sacubitril. So now the mechanism of action, you know that valsartan is receptor blockers, so which block angiotensin to receptors, and then you get neprilysin inhibitor, that is sacubitril, which inhibit neprilysin, so that which inhibit breakdown of vasoactive products like BNP, ANP. However, still we don't know the exact mechanism which improve the cardiac outcome by sacubitril. There are so many theories. So it increases the diuresis, reduces the blood pressure, and improve the endothelium. But still, no one knows the exact mechanism by which the ARNI improve the cardiac outcome. So, but anyway, now there are several trial and meta-analysis done over the last decade. And if you go through these meta-analysis, of all these molecules, RNA is superior to ACE inhibitors. But there's still issues. Because initial trial, which was done in 2014, compares with enalapril 10 milligram, and then with sacubitril and valsartan. And there was nearly 20% reduction those who are treated with RNA. But subsequently, there were several other trials which compared over ramipril and the plindopril. There's no much difference. However, to date, there are meta-analyses, and after all the meta-analysis, there's nearly 20% relative risk reduction in cardiac mortality and also hospital admission and progression of a disease. But none of these trials done over 2 years. So we don't know the long-term outcome of RNA. One of our main concern about RNA, which inhibit the breakdown of most of peptides. So that sometimes the neprilysin is important to break down harmful molecule like especially amyloids. So that there's theoretical chance that long-term use, we can end up with amyloid deposition in brain and some other important organs. So we don't know the long-term outcome of RNA. And also, if you look at the cost, it's very expensive. It's maybe 30,000 for one molecule. So if you look at your the family income is 100,000. So if we are prescribing a drug which costs for 30,000, so they have to anyway cut down their budget on healthy diet and also mental stresses. So the benefit you achieved by the molecule may be blunt away due to the other stresses and the lack of good nutrients. More than that, so as we are in third world country, just choose so my practice is, those who can afford, maybe young people. So I'll initially, if their monthly income is over 500,000, so maybe I offer RNA for a while. When the ejection fraction is improved, sort of I switch into ACE inhibitors. And also we have to, if patient can afford, so the next available molecule is ACE inhibitors, ACI. So it's not a bad molecule, so which block the angiotensin-renin system. And also, if you look at the meta-analysis, there's nearly 11% reduction in all cause of mortality. So number to need treat is like 50. And is there any difference between different type of ACE inhibitors? Yes. So if you look at the first generation ACE inhibitor like captopril, enalapril, this is short acting. So that though you treat, there is no 24 hours blockage of this angiotensin-renin system, so that you are not getting the total benefit. But if you treat with the newer molecule like ramipril or plindopril, so you may get a better outcome, and also side effects are less. And out of all these ACE inhibitors, the lisinopril is not proven to be beneficial with regard to reductions in cardiac mortality. But my question is, in our patient, so what percentage of patients are not on ACE inhibitors without having real contraindication? If you go through the clinic records, maybe 30-40% of patients are not on ACE inhibitors. So by changing your practice today, we can prolong their lifespan. And also then what is the place for ARBs? So now the guideline recommended those who cannot tolerate ACE inhibitors, or when there is ACE inhibitors are contraindicated, go for receptor blockers. Depending on single of the 1 or 2 trial, that is CHARM alternative and few other trial. But if you look at the data analysis of meta-analysis, ARBs failed to demonstrate the reduction in cardiac mortality in heart failure. But look at in our clinic records, the most of patients are on losartan or maybe some other receptor blockers. So we'll try to change the simple change. You can get a big outcome. So try to, when you get the clinic record, when we have diagnosed heart failure, and try to change into at least AC inhibitors, and those who can afford, uh, try to offer them on. And then the next important molecule is beta blockers. The beta blockers, you know the mechanism of action. So it block beta receptors so that it inhibit the sympathetic activation related cardiac remotely. So we have enough data over the last maybe 4 decades, and beta blockers reduce heart failure related death by 25%. So if you look at the number to need treat is 1 is to 25. So it's a very good drug. And but there are only 4 beta blockers are proven to be beneficial in heart failure. That is bisoprolol, metoprolol XL, carvedilol, and nebivolol. But still, there's any difference between these molecules? Yes. If you look at these newer beta blockers, the nebivolol and carvedilol. If you look at carvedilol having the what alpha activation, so blocking also, so that there's a vasodilatory effect. And also most of beta blockers associated with insulin resistance. Insulin resistance is something which increases the mortality related to the all the vascular event. So that if you can give a beta blocker which has a neutral effect on insulin resistance, you can get the maximum benefit. So carvedilol or nebivolol is slightly better than the metoprolol and bisoprolol, but what is our rates of beta blockers in patients with heart failure? Maybe they are maybe more than 50% of patients with heart failure not on beta blockers. Maybe due to some reason. Maybe you have labeled it as bronchial asthma, but bronchial asthma are contraindications. And also sometimes we tend to take beta blocker when patient admitted with acute deteriorations, so that we are not discharge them with beta blocker. There are so many other, and also sometimes we just start them on ibuprofen. So beta blockers, we have to make sure that beta blockers play an important role, so that there's a 25 relative risk reduction in patient with heart failure with reduced ejection fraction. So there are only 4 molecules, of which maybe nebivolol and carvedilol having extra benefit because the insulin interaction is minimum, and also both having vasodilatory properties. So try to use beta blockers in patient with heart failure, liberally. And then the third group of molecule is we are again blocking another important step by blocking aldosterone. It's aldosterone antagonist, as aldactone, spironolactone. So there's impression that aldactone is a diuretic. So it's a diuretic, yes, but we are not using the diuretic dose. If we use diuretic dose, so definitely there's no positive outcome. It's going to be a negative outcome. So we are using 25 milligram, maximum of 50 milligram. It's not a diuretic dose that which block the aldosterone. So aldosterone associated with the remodeling cardiac fibrosis. So 25 milligram block almost all receptors. So that is one of important molecule, because there's a 37 to 40% relative risk reduction. So number to need treat is less than 15. So that you make sure that your patients are on the spironolactone in the absence of contraindications. So contraindication include very high potassium. Not here it is 5. I don't think this 5 is not a contraindication. And EGFR. Now, sort of even with the low EGFR, we are using this spironolactone. And then the fourth category is SGL2 inhibitors. So that is actually very recent, not very recent. In last decade, it's a drug has become in in heart failure, and it's a drug of not it's initially drug was invented to you use in diabetes, but now no longer it's used in diabetes, but it's a drug in of cardiologist. We use it for spectrum of disease, but especially in heart failure. We don't know what the exact mechanism how this SGL2 inhibitors reduces those all cause of mortalities. But there are several predictions, again, hypotheses that I think induce diuresis, reduce the blood pressure, improve the lipid profile, improve the insulin sensitivity. There are so many, but still we don't know exact mechanism by which it's going to improve the final outcome. But we know that SGL2 inhibitor, again, we have meta-analysis. There are at least more than 30% liver reduction. So the number to need treat is nearly again 15 patients per year. So I'm not going to talk more about more molecule about managing on heart failure. So mainly I'm concentrating on four molecule, what we call quadritherapy. So if you treat with this quadri treatment for molecules, so what we can achieve. So if you combine treatment, you can achieve very good outcome. There's nearly 50% reductions of cardiac death and nearly 50% reductions of all cause of mortality. And is it working? Yes, it's working. But if you look at these patients on conventional treatment and or the complementary treatment with ARNI, SGL2 inhibitors, aldactone, and beta blockers, so you can extend their lifespan by another, maybe if you are under 55 years of age, you can expand their lifespan by another maybe 6 to 7 years. But over 65, you can still you can extend their lifespan by another 3 to 5 years. So these molecules are working, there's no doubt. But we have to implement this treatment depending on their clinical presentations. And then we'll talk about the mid-range heart failure. So heart failure where ejection fraction is nearly 41 to 49%. Now the pathophysiology is different. So there's behavior is more or less heart failure with reduced ejection fraction, but the activations of neurohormonal system and sympathetic activation is not great as patient with heart failure with reduced ejection fraction. So the drug which are used in heart failure with reduced ejection fractions not going to play a major role in this category. But they may be having other indication to give this drug, ACE inhibitors, beta blockers, because they may be having underlying hypertension, ischemic heart disease, previous heart attack and all. But in the absence of any indications, their use is not as strong as in patient with heart failure with reduced ejection fraction. So that its level of recommendation is to be. We don't know. But still one molecule, SGL2 inhibitors, because SGL2 inhibitors spectrum of the heart failure from normal ejection fraction to low ejection fraction has a place. In this group also, SGL2 inhibitors, there's no much reduction in mortality, but there's a significant reduction in need for hospital admissions, and also improve the exercise tolerance and improve the ejection fraction. So this depending on two main trial, that is impact preserve and some trial. So that patient with heart failure with mid-range ejection fraction, you have to make sure that they are on SGL2 inhibitors. But other drugs, we don't know whether these drugs are actually working or not. Now, the most typical part, that heart failure with preserved ejection fraction. What is heart failure? Is it existing? There is one question. Is it heart failure? Another question. Actually, heart failure with preserved ejection fraction is not a primary heart disease. It is a cardiac manifestations of other disease like CKD, diabetes, so and so. So that the pathophysiology in patient with heart failure with preserved ejection fraction not really understood. But now there's hypothesis that it related to the this inflammation and activations of interleukins. But still, we have not achieved the major breakthrough or milestone in the management of heart failure with preserved ejection fraction. So we don't have any drug coming under the class 1A indications because we don't have any trial proven drugs. So why this category is difficult to treat and difficult to diagnose? There are several reasons. First thing is diagnosis is still a challenge because so many other diseases, comorbidities mimic as heart failure with preserved ejection fraction. So they come in shortness of breath, fatigue, and there are so many, they can mimic the heart failure. And also, it's not a primarily heart disease, cardiac manifestations of other comorbidities. Very difficult to diagnose. You have to have very high degree of clinical suspicions because echo evidence of diastolic dysfunction. So when you are sending patient to cardiologist, as we just go through and we said that patient having diastolic dysfunction is stage 1, 2, or 3, is neither specific or sensitive to make a diagnosis of heart failure with preserved ejection fraction. So that is most important. Actually, it's better to to underdiagnose heart failure with preserved ejection fraction because there is no proven drug. But our problem is we are over-treating it because based on echo finding, sometimes we are treating this patient with unnecessary molecule like AC inhibitors, beta blockers, and all. So you are getting only the adverse outcome. So heart failure with preserved ejection fraction, we want to make sure that it's not a heart disease, it's a cardiac manifestations of other diseases. So this echo finding I'm not going to read on because this is mainly for cardiologists. So echo gives some clue, but it's still you have to make sure the initial definition heart failure syndrome. So echo is just supportive. So I'm not going to go through because again it's more cardiology part. Basically those who are doing echoes but so there's scoring system for diastolic heart failure with preserved ejection fraction. Depending on the scores, you can get the probability with a higher probability, intermediate probability, or lower probability. So these are the scoring you get for atrial fibrillation 3, hypertension 1, and obesity 2, so and so. Depending on scoring system, sort of you can get an idea in which category your patient is falling. And finally, we don't have much options available in patient with heart failure with preserved ejection fraction. We don't have any drug which reduces the mortality, cardiac death, and non-cardiac death. Only SGL2 inhibitors reduces the need for hospital admission, by nearly 20%. But there's no reduction in cardiac death. And also, if you look at ANI, maybe patient with ejection fraction in lower range, when the ejection fraction is less than 55%, 57%, there may be slight. It is a green light. Still, there's no significant reduction in mortality. And also, just I have to mention that all the ANI trials is not done more than 2 years, and all is collaborated with pharmaceutical companies. So you have to be concerned about whether it's totally biased or unbiased. And also LDAC-tone, depending on the TOPICAT trial, there's a phase for LDAC-tone when the ejection fraction is less than 40%, and especially in female. Right. Other thing is heart failure with improved ejection fraction. In our day-to-day clinical practice, when the ejection fraction improved, we think that we have treated, we have cured, not. So it's important that though the ejection fraction improve back to the normal, I have mentioned that it's a progressive disease. Don't stop your medicines, especially beta blockers, AC inhibitors, and SGLT2. Don't stop it. What happens will stop after 1 year there will be 50% chance of relapsing. So again, patients, 50% of patients stop the treatment, so will end up with heart failure. And one last talk about acute decompensation. This is most important. This, uh, many patients come with acute decompensation. Our practice is to stop all the medication that they are on. Especially the first drug we are stopping is beta blockers. Problem that don't stop beta blockers unnecessary. One reason is stopping beta blockers in acute decompensation, like you are giving iron drops, because in acute decompensation sympathetic activation is very high. So that blocking beta blockers is, taking blockers off. So it's like, you are giving iron drops. So don't stop beta blockers unless there's a real indication like cardiogenic shock or severe bradycardia. Otherwise, continue. And once if you stop it, and try to start before discharge. Otherwise, they won't be on beta blockers throughout their clinic follow-up. And also, according to very recent meta-analysis, the rapid uptitrations of drug is associated with better outcome. So you don't need, uptitrate very slowly, uptitrate rapidly, and also, you don't need very high doses. Try to give 4 molecules together, maybe in low doses, so you can get a better outcome. So I think so. I made it most of your heart. So if you have any question, there's now time for questions.
Thank you, Priyantha. Any questions from the audience?